My privilege to introduce Professor Manjari Tripathi ma'am, who requires no introduction in the field of epilepsy. Ma'am, I will hand over to you for your talk. Ma'am. Thank you.
Thank you, Dr. Snigdha. And I'd like to, at the onset, thank the organizers of APNU. My talk is dedicated to all the senior residents all over the country. Hopefully they are watching because they have been the front line of caring for our patients during the COVID. So this talk is dedicated to them and of course to the patients who come to me with drug-resistant epilepsy. I've been asked to talk about evaluation of the epileptogenic network and novel biomarkers. So this is more or less a conceptual talk. For having more on, the semiology, pre-surgical evaluation, the Indian Epilepsy Society is having epilepsy surgery subsection meets every third Sunday, and please attend that. I'm sure all members of IES on board here are getting notices for those meetings. Now, it's essential that we understand that, is it showing? Are my slides showing? Yeah. So basically, what exactly is going on within the brain when there is an abnormal network? Initially, we talked about the lesion, then we talked about the zone, and now the concept is the zone. I would be touching upon the recent. It would be impossible to go ahead with the talk without recognizing Wilder Penfield. And of course, Penfield had his compatriot, which was Jasper, who was the neurologist, and Penfield was the tremendous amount of work in the 1960s to help us understand these concepts, which still hold true as of now. So 1956, part of the seizures and subsequently propagating them onwards, that is responsible for the drug resistance and the epileptic zone and networks. Now, Wilder Penfield, for all the residents here, one must know that he is the cartographer for the homunculus. And basically, he described the homunculus based on his epilepsy experiments on stimulation of the brain peroperatively. Also for the residents, no residency training is complete without reading the complete works of Wilder Penfield, which will give you the philosophy of a human being, of the mind, and of course of understanding epilepsy and brain function, which is what attracts everybody to the field of epilepsy. So please, in your free time, all these books are available in an audiobook format as well as soft format, and you can read it on your Kindle whenever you have time. Then came the era where there was, of course, Talrac and Bancourt, and they are again from the Montreal Neurological Institute, and they used to implant patients with stereo EEG electrodes way back then. And then they came up with the concept of the network, which was forgotten for some time and now has taken a trend again. And then we moved to 1990s, where Luders essentially defined the epileptogenic zone, which is the area of cortex which is necessary and sufficient for initiating seizures and whose removal or disconnection is necessary for complete abolition of the seizures. But if the residents want to read this complete history, the best article for this is by Lara Jahi from Cleveland Clinic, which is published for a free download in 2018 in Epilepsy Currents. So please note this reference, because in case you really want to get into the field of epilepsy, this is the paper to go to, which looks at the development of the zone, the lesion, the network, and thereon. So what is this epileptogenic zone? It's a hypothetical zone. It's a theoretical zone, as I said, defined by Luders as the minimum amount of cortex which is required to be resected or disconnected to make the patient seizure free. For that, one must be able to identify the epileptogenic lesion, and sometimes you may not have the lesion. The reason you need to identify or try to identify the epileptogenic lesion is because the outcomes for intervention when you have a lesion versus when you don't are significantly different. Then, of course, you have to identify the symptomatogenic zone, which is what we do by doing the video EEG and looking at the semiology in history and the video EEG. We come to the symptomatic genic zone, and then the ictal onset zone, which is identified by the video EEG, ictal onsets, as well as by the ictal MEG, etc., and ictal SPECT. The irritative zone, which is the area which generates the spike, which is what our routine outpatient EEG picks up. And of course, the functional deficit zone, which is the impaired cortex or impaired area around that particular epileptogenic lesion or, the epileptogenic zone, which is going to produce dysfunction in your patient. And hence, all these need to be measured and all these need to be evaluated before we even think of intervening in a patient. And essentially, if you take the last D of this diagram to be the epileptogenic lesion, then the essence of epilepsy surgery is to identify this lesion and the network it produces, abnormal network it produces, and either remove this lesion by doing a lesionectomy or resective surgery, as we call it, or by disconnecting this lesion from the rest of the cortex, which is what we call as disconnective surgery. And sometimes we cannot do either because multiple lesions or diffuse lesions, or it's on the eloquent cortex. Then we go in for neuromodulation. And there are procedures which are typical of these. For example, resective would be a amygdalohippocampectomy, a disconnective would be a hemispherotomy or a callosotomy, and of course, neuromodulation would be VNS and DBS. The essence of doing all this evaluation is to have a spectrum of a team of people looking at the person with epilepsy. And this team consists of, a network of people who are working towards a common goal without competition, but in collaboration. A neuroradiologist, a neurosurgeon, a technician, a nurse, a psychologist, etc., and nuclear medicine specialists who are evaluating the patient in details. And if your patient cannot fit into surgery, then of course you should have an option of a diet program for these patients. And so this is basically the essence of how we would get snapshots into the epileptogenic zone through the help of all these specialities. The simplest prototype of this is mesial temporal sclerosis, which you can see here. There's a smaller hippocampus here. And of course, the temporal lobe on the left is also small. So this is the lesion. This is the lesional zone. Okay. Now we know that just removal of this is not going to make the patient seizure free. Otherwise, selective amygdalohippocampectomies and selective ablations of the hippocampus would have rendered surgeries not required. But this is not so. So we as neurologists need to identify from where the seizure is coming. Is it coming from that atrophied hippocampus or is it coming from some other area? So we have to identify the ictal onset zone, and then we have to identify the interictal zone, which is the irritative spiking zone, which we do by the interictal EEG or the interictal SPECT and PET. And of course, this is a larger area in the whole spectrum of things. And then based on these snapshots, which is the minimum required for MTS. For MTS, you really don't require extensive investigations. You just need these, that is a video EEG, and of course, your interictal EEG. If it's a dominant temporal lobe, you need the neuropsychologist to give you inputs. If it's the dominant temporal lobe, you need a functional MRI and you need a VADA. So this is the minimum investigations for identifying that epileptogenic zone, which is a minimal amount of tissue which is required to be removed. And in this case, it happens to be the amygdala and the hippocampus and parts of the temporal neocortex, sparing the posterior superior temporal area of the cortex and sparing the area behind the labes vein in the cortex. So this is about the mesial temporal sclerosis. In a sense, if you're asked about the epileptogenic zone, you have to define all these zones. You have to define how you're going to detect or pick up these zones. So irritative zone is the interictal EEG, interictal SPECT, the MEG and the PET. The ictal onset zone is going to be the video EEG, the SEEG, the ictal SPECT, the MEG. ictal Meg that is. An epileptogenic lesion is the lesion which we are seeing in the MRI and of course in tissue pathology. The symptomatogenic zone is what we observe in the history, semiology, as well as what we observe in the semiology in the video EEG. And the functional deficit zone can be defined by the PET and interictal SPECT and EEG. Now, why is it essential that in more complex cases, we move to widening the snapshots? Basically, we need to widen the snapshots in extratemporal mesial temporal sclerosis, particularly in certain cases, because each snapshot is giving us distinctive evaluation profiles. So there is no single technique which is ideal for identifying the epileptogenic zone. You really need multiple snapshots which are provided by doing your SPECT, by doing your MEG, and by doing your PET, etc. And these will give us increased sensitivity and specificity to which is the epileptogenic zone. And hence you need to widen the spectrum of evaluation. You need to have the complete evaluation so that as we know, based on what Luder's described, that no single test will tell you the complete epileptogenic zone in complex cases. And this has been laid down in this paper, which was defined by the Pediatric Epilepsy Surgery Subcommission. Why I say Pediatric Epilepsy Surgery Subcommission is because the pediatric etiologies are more heterogeneous. We don't often see such heterogeneous etiologies in adults. So the pediatric epilepsy field provides us the need for understanding all these various investigations. So the PET you're going to do wherever there is non-convergent data, there is multiple lesions like tuberous sclerosis. The SPECT you're going to do wherever you are not able to see anything in the MRI. The MEG also you're going to do in certain circumstances. And these have been laid down by the subcommission. This is a landmark paper which should be read by the residents to understand where it is highly recommended. H is highly recommended. And O is optional, and L is, you should do it if you can, but it's of little use, and O is optional. So wherever you find there are lesions which have insufficient margins or subtle lesions, like you see in FCD type 1. Now there you would want to do the PET, SPECT and MEG. Wherever you have lesions where there is MRI negativity, that is nothing is seen on the MRI, which you have got read by the epilepsy neuroradiologist, you are going to look at these various zones by doing the PET, SPECT, MEG, etc. And of course, wherever there are multiple lesions, wherever you want to identify functions, again, you are going to use various investigations. So this paper really gives you, in a sense, the need after evaluating in an evidence-based manner the various literatures which were available to us by 2014. We have set protocols, and at least at our center, we try to at least get a good MRI. Some of them walk in with the MRI with the lesion. So if the lesion is seen in the MRI, that is substrate positive, and usually this is mesial temporal sclerosis or gangliogramas and DNETs, then we move ahead straight away with simple investigations like video EEG, MRI and EEG. And we don't need to do the advanced investigations if everything is concordant. But if things are discordant with these simple lesions, we still need to do a PET and SPECT and then proceed for epilepsy surgery based on concordance. However, when there's no lesion seen on the MRI, it becomes a more difficult scenario, and there you really need to do multiple investigations and then, go ahead with even sometimes a stereo EEG. So they become more complex in identifying their epileptogenic zones. And sometimes there are multiple lesions. There are lesions which cannot be tackled by a resective surgery because they are on the motor cortex or on the visual cortex. That's where you would like to do palliative procedures like MSTs or callosotomies or hemispherotomies. And these are given in our recommendations based for the Indian scenario. Now, it is important then when we work up these various, by various investigations, we try to narrow down on the epileptogenic zone, which is a hypothetical zone, that we try to establish concordance and agreement of these investigations based on how well we have done these investigations. And based on this concordance, then we go ahead with epilepsy surgery patient management conference, and then we take them up for a surgery based on when they get their times and dates. So this is a more complex patient. Here you can see this patient really, had undergone a surgery for a calcific lesion in a center outside, not at AIIMS. And the calcific lesion was situated in the mesial occipital region, you can see here. And this was removed. So the post-op MRI, which is seen in the second and the third MRI rows, shows the lesion is removed. But the young girl continued to have seizures. And she came to us because these seizures continued. Now, when we did her ictal spect, now ictal spect has to be done within 30 seconds of the ictal onsets, preferably identified by a simultaneous EEG, which is ongoing. So you have to inject the ECD within 30 seconds. Otherwise, there's going to be an ictal switch to the other side, or you're going to miss it and you're going to find propagation in your ictal spect. So the ictal spect showed a hot spot in the temporal lobe, which wasn't touched in the first surgery outside. And the PET MRI fusion also showed a relative hypometabolism in the left temporal lobe. And the Meg showed us clearly that there was propagation from the mesial occipital, which was going on to the temporal lobe. So the innocent bystander, which was the normal temporal lobe, was causing the seizures, which was still happening despite removal of that calcific lesion. But how do you remove the dominant temporal lobe? You really need to prove that the seizures are still coming from the hippocampus. And hence, in this patient, which is a little more complex, you utilize stereo EEGs in an economic manner, put them into the hippocampus, and then look at the ictal onsets, which are coming from the anterior hippocampus. You can see the recurrent spurts of spike and wave, followed by bursts, which are coming from the left hippocampus. And that's where you can go and remove it confidently without producing a deficit in the patient. Now, a little more complex is children. To identify the epileptogenic zone in children, it's a little more tougher, particularly when they're less than 6 years of age, because the lesion may be very focal. The interictal abnormalities may be broader, they may be almost generalized, and the semiology may also be generalized. And this is shown in this beautiful paper, landmark paper, which all of you must read, by Doug Nodley, where he has clearly shown, based on his analysis of several cases, that less than 6 years of age, a focal lesion will manifest with myoclonus or with tonic seizures or with spasms, and rather a generalized seizure morphology. Whereas when the child grows more than 6 years of age, you are going to find unresponsiveness come in. It's also important to remember that despite having the lesions, sometimes you do not find the ictal onsets on video EEG coming from the lesion. And this is more so whenever the lesion is in the central cortex or in the parieto-occipital cortex. As you can see here, the central cortex does not have the dark blue. Now, what does this dark blue signify in this graph? The dark blue is, almost 90% or more of your seizures coming from that lobe. If you have a seizure etiology around the central cortex, the ictal onsets on your video EEG are not going to be 90% or more coming from that area. In fact, 67% you will get about 25. In 25% you'll get 67% onsets from that area. So particularly when you have posterior cortex epilepsy, particularly when you have central and parieto-occipital epilepsy, you are going to have problems in localizing just by the video EEG. And that's where you need to do your ictal spec, that's where you need to do your PET, etc. and Meg to help you out in these complex cases. So let's hope the video plays. So this is a young girl presented in CPC in one of the econs. She came to us with myoclonus and tonic seizure. So you can see the myoclonus, which is a bit asymmetrical, right foot, followed by a tonic spasm. And if you see her EEG, her pre-ictal interictal EEG shows drastically slowed background. She had a working diagnosis of Lennox-Gastaut syndrome, and there were some sharp waves and slow waves seen occurring in the posterior head regions for whatever reasons. And then as she progressed into the ictus, you can see these sharp and slow waves which came over the right frontocentral area, and then almost look like a secondary bilateral synchrony. That is bilateral synchronous generalized discharges. But if you look very carefully, the onsets of sharp is better earlier on the right hemispheric or right hemi area. So that gave us, understanding, though she's having tonic spasms in sleep, there could be something focal in this child. And this is how the seizure progresses, and this is how it kind of halts. And if you look carefully, the right frontal shows a cortical dysplasia. So in pediatric patients, even though the lesion is focal, you can find generalized abnormalities in the interictal EEG. You can find generalized abnormalities in the ictal onsets, as I told you. And these patients will still respond very well to epilepsy surgery. So finding generalized semiologies in pediatrics does not make us think of a generalized epileptogenic zone. You have to try to find some focal features based on your imaging and based on your clinical observation and interictal EEG, which can give you clues to a focal etiology in refractory generalized seizures in pediatric population. And of course, she underwent a surgery. This was an ECOG. So you can see this is a typical per-operative ECOG in a patient who undergoes surgery for a cortical dysplasia. There will be these runs of and bursts of polyspikes and spikes, which will come and go in trains. And you really need to remove these and make the patient seizure-free. Now we move from the concept of zone to network. Now it's very eclectic to think that everything is a zone. But the brain cannot be compartmentalized. The brain is one, but there are divisions into lobes and sublobes. But each one of these is connected by longitudinal fibers, by U fibers, by different fascicles. So really it's difficult to pigeonhole these lobes into not being interacting with each other. And that's where the epilepsy specialists shifted their focus from the zone to the network. So now no more we talk of the epileptogenic zone. We try to identify the epileptogenic networks. And what are these networks? So whenever we have a long-standing drug-resistant epilepsy, these patients will have evolution of networks or evolution of connections in their brain, which will be bizarre and unique to each patient. And these patients will have some kind of kinetomic approach, which has been defined by Jerome Engel and my mentor, John Stern from UCLA. And you can see these, the network concept really makes a shift from a static concept to a highly dynamic concept, in that even a lesion and a focal zone can cause dynamic changes and fluctuating changes in the whole brain. So basically, the shift from zone to network is that the zone is a static component and a concept of single or multiple components, but epileptogenic network is a dynamic concept with multiple zones interacting with each other, and some of them will be hubs, and some of them will be spokes, and some of them will rapidly transmit to the other hemisphere, some of them will remain confined to the same hemisphere, which is what we see. And hence, there has been a shift in the concept from just defining the epileptogenic lesion to the zone to the network. And this is what epilepsy, evaluation of drug refractory epilepsy is now. Now, the network can be identified by semiology. How does the semiology evolve? What is the symptoms in the beginning and signs in the beginning? And what happens in the middle of the seizure and what happens at the end of the seizure, which is what we see in the video EEG. And then, of course, we can have networks which are compact because the duration of epilepsy is less and the patient has a less severe epilepsy. But we can have widespread and diffuse networks which require more investigations like Meg and SEEG. It's also important that once we do these investigations, we establish the concordance between these investigations, as I told you before. And based on evaluation of our experience, what we found is that 8-year outcomes, long-term outcomes, were not bad, were akin to any other center in the West for temporal and extratemporal. So for temporal, it was around 58 for 70% over 8 years. And for extratemporal, it was about 58%. So they were good outcomes. We also evaluated these patients by ictal MEGs. If they happen to have a seizure during the Meg evaluation, we do a 3-hour Meg recording. And Meg is available in 2 centers in India now, so the residents should know about it. And this is the ictal MEG, which clearly shows us the ictal onsets. So basically, we have moved from to a nonlinear regression analysis by various methods to identify these networks by various investigations, as I mentioned. Now, the last part of my talk, last but not the least, is the biomarkers. Now, for this, the best review article is written by my team and our Center of Excellence. This is available for free download. Please use this as a reference article, particularly when you're preparing for exams. These biomarkers can be identified as basic biomarkers, which are the synaptic molecule, the kinases, inflammatory biomarkers, epigenetic biomarkers, and metabolic biomarkers, and the electrical biomarkers. So we can divide them into these two types. And based on what we have shown, at least worldwide from our center, published in Genomics, there are certain RNA, microRNA changes which happen in tissues of our patients, as well as in Nature scientific reports, which we have shown in focal cortical dysplasia. So not just in mesial temporal sclerosis, there are different aberrant RNA analysis and miRNA changes in patients of focal cortical dysplasias. There are changes at inflammatory biomarker levels, as published here again and published again widely by various series from the world. And of course, this paper is almost accepted in neuroscience letters, where we have shown, changes in the metabolomics of the lipidomic biomarkers. So these are various biomarkers. It's basically a theoretical probability that you get asked about this in your exam. So you please read that review article, which I just mentioned. We've also tried to zero down on the neurochemical biomarkers based on the age of onset of seizures in focal cortical dysplasias. There are some patients of focal cortical dysplasias which have seizure onset very early, and some patients of focal cortical dysplasia which have seizure onsets very late. And we have demonstrated changes in the gamma receptor function in these patients based on the age of onsets. The electrical biomarkers, which we are seeing, is as well as labs across in India, in NIMHANS, as well as in the world at UCLA, are seeing are the HFO biomarkers. Now, HFO, again, is a theory question. We are observing it in our patients. These are activities which are above 80 Hertz, which are not picked up by the routine EEG or OPD EEG. They require equipment which has the capacity to record beyond 2 kilohertz, and traditionally between 2 kilohertz and 10 kilohertz of EEG. You require a good storage capacity in your EEG systems to detect these. And we have been able to study these biomarkers in our difficult patients by MEG as well as by high density EEG. So this is the MEG. It's just like the MRI machine, but it's a helium cooling unit, which is there here. This is my team of 4 nurses, 2 technologists, 2 technicians, and 2 scientists who work in my lab here. It's a very labor intense procedure. MEG is again a short note for you all. It requires, registration with the MRI. And this is how we pick up the ictal HFO. So this is clearly an ictal HFO. You're seeing the HFO picked up. And these are the slow waves. This is not from my lab because we haven't started working on the ultra slow wave. But the ultra slow wave delta is also a mechanism to pick up these ictal activity. And then we fuse it with the patient's MRI. This patient had a normal MRI, but the ictal HFO in her clearly localized to the right frontal region. Now, in the MSI, this is the MSI image you're seeing, the right is the right. So this kind of helps us get another snapshot. And if this is concordant with the ictal spect, it helps us approach this difficult patient with probably implanting a stereo EEG if an MRI is completely normal to create a hypothesis and then remove this cortex. This is an interictal HFO, which we are seeing here in the basifrontal, middle frontal region on the left side. Similarly, this is the high density EEG recording in my lab showing the HFO. And this is the ictal EEG HFO. This is the high density MEG. So when we do MEG, we do high density EEG also because the EEG is attached. As you saw, the EEG cap being attached. And we can pick up the signals, the same HFO in the we also have a high density EEG, which is a 128 channel EEG. And you can see here, this is the patient sitting here. It's quite a simple procedure. It has this whole dome over it. The dome is so that we can co-register with the MRI and find out where the HFOs are in the high density EEG. So these are the biomarkers based on the electrical activity, the ictal HFO and the interectal HFO by Meg and by high density EEG. So basically, identifying the epileptogenic zone and network is now a concept which involves not just studying the patient's semiology, the ictal onsets on video EEG, the PET, SPECT, multimodal fusions thereof, but also goes into the basics of epilepsy and identifying based on from bench to bedside and from bedside to bench evaluation of our patients who present to us and consent to allow us to do all these investigations to understand mechanisms of epilepsy further. And this is how our lab is structured, how our Center of Excellence is structured. There are 4 verticals: the Meg lab, the Professor P. N. Tandon Epilepsy Neurobiology Unit, the Electrophysiology lab with the high density EEG. And this is the team, and hence I'd like to conclude my talk. And if there are any questions, I could answer. Dr. Bhargavi will be showing one of our cases in the case discussions and, kind of dealing with the various zones as she takes you along those cases. Thank you.